Thank you very much. So, good afternoon again. So, I think for the better flow, so I'll just move on for the TCD part. So, I think my life is much easier after Dr. Romani has already mentioned about everything. So, actually, for TCD, it's pretty much similar to the TCCD, except for the blindness. I mean, we don't see the arteries, we don't see the pictures, we don't see the anatomy, but we can still work on it. So let's go start with a case. This is a 84-year-old female who presented with repeated attack of right arm weakness. Actually, it started off 2 days ago when she experienced transient right arm weakness and some difficulty speaking, maybe moderate aphasia. And then it stayed for only 5 minutes and then went away. 1 day later, she developed another episode of right arm and right leg weakness again for 10 minutes. And just the day that she came to the hospital, she developed another attack of right arm weakness. This time it was mild, lasting for 30 minutes. She has history of hypertension, diabetes, and dyslipidemia. And on exam, when she arrived to the hospital, all the symptoms were gone. She was back to her normal state, no neurological deficits. So of course, this sounds like a TIA, repeated TIAs on the same side, probably in the hemisphere. It's not very stereotype, meaning the TIA is not similar every time it happens. So we did a CAT scan of the brain, which shows some old lesions on the left side, maybe some old infarct, but she didn't have any symptom of that. Thank you very much. As I said, he's behind everything. So, okay, a little bit of infarct over here. So, what's next? So, this patient is coming in with repeated TIAs. Now she's back to her normal neurologically, but she has a high chance of having another TIA or even a bad stroke. So, I think it's very important that we search for the cause of this TIAs. And since the TIA is happening on the same side all the time, it's very likely that it comes from something, the blood vessel on that side. It's very unlikely that this is going to be cardioembolic because it happens on the same side all the time. So I think next thing that we should consider is to look at the blood vessels that supply the brain on that side, right? It's likely to be in the territory of middle cerebral artery because she's having weakness in the arm. Sometimes she had aphasia, so meaning that it's cortical involvement. So it's likely to be the MCA territory. So when you want to look at the blood vessels that supply the MCA, you look at the carotids, right? The carotid on that side, and also the MCA on that side. So we actually looked at the carotid, and Dr. Johanna Kusuma will talk about that later. But we did look at the carotid of this patient, and it turned out that the carotid shows a mild plaque and small plaque over there, but no significant stenosis. So the carotid is not the cause of the TIAs. So we have to look further to the vascular territory that supplies the MCA, which is the intracranial part. So that's why TCD comes along. So transcranial Doppler or TCD, actually, this is coming back in time a little bit. Dr. Romani talked about TCCD, which is a newer version of TCD. In the old days, we are very used to having this blind TCD. It's very convenient. You can carry it around. The machine is quite small. And if you manage to master it, I think we are very competent that we know what vessels we are looking at. So just simply want to explain to you what is the CCD, how to perform, which is pretty similar to TCCD, and how can we identify the vessel because we don't see the anatomy. So how can we identify them? And then just interpretation. So actually, TCD has been around for quite a long time, since 1962. So at first, it was thought to be a stethoscope of the brain. So we use the probe, ultrasound probe with low frequency, usually true 2 megahertz, and signal would enter the cranium, and we get the signal from the blood vessel. And it has been tested in many studies that TCD is very good at picking up the stenosis of the blood vessel in the brain. So these are some of the examples of the sensitivity and specificity of TCD comparing to CTA and DSA. And it's actually, I would say, operator dependent quite a lot. So there are advantages of TCD comparing to some other techniques that we use to identify or to diagnose stenosis of the blood vessel. So it can be done at real time. You can measure the blood flow at real time. So you know exactly how much blood flow is going in, the velocity of blood flow, and the direction of blood flow at the very moment. It's of course non-invasive. We're not using any harmful things, and it's portable, as mentioned earlier. We can move it around, but it's very. I think it's very highly tolerated by patients. You can just put the probe in, and it's no harm or anything. It's not painful, so it's tolerable, and relatively it's inexpensive. There are some limitations. Of course, it's operator dependent. We don't see the arteries, so it depends on you to define the arteries. And in patients who are not cooperative, they're moving around, maybe it's not very good. And there are some patients who had difficulty, who had some anatomy factors which not allow us to find the arteries. As mentioned earlier, that some old Asian lady would have bad temporal window, maybe 10% of those, 10% of the ones who we do TCD, we won't be able to find a window. And some variations of the anatomy, because we don't see the anatomy, so we just blindly look at it, some of the variations, so we won't know. And then the angle of insonation, so we can't correct it because we don't know the anatomy. So how to perform TCD examination? It's actually the same as Dr. Ramani mentioned earlier. So you start off with positioning the patient. Usually patient can lie down in bed and we are at the head area of the patient, or in some windows, like for example the occipital or transforaminal window. Patient needs to lie on the side, or sometimes we sit the patient up and let them bend their head as much as possible. So we open up the foramen, the foramen magnum, to insonate the vertebral and basilar artery. So, and then we take the probe and then we set up the machine, and then we kind of put the probe on the patient's head. So these are the common, actually the first 3 are very common areas that we would insonate the patient. The submandibular, sometimes we do it to kind of look at the intercarotid artery in the neck and calculate something. Dr. Navarro will probably talk about that later on for the calculation for the subarachnoid hemorrhage. Anyway, so these are the 3 common areas that we would insonate the vessels: the transtemporal, the orbital, and then the suboccipital or transforamen magnum, which is the same area. So this is where we usually do the TCD, sitting at the one end of the bed and trying to do the TCD exam. So these are the 3 windows that are normally done. So since it's blind, so we have to identify the blood vessel. So how can we know which vessel we are looking at? So the first thing is that which window you are looking at, right? So you have to know which window you are putting your probe on. When you look at the tracing, you need to find out which window you are looking at. So transtemporal or orbital or occipital. And then the angle of the probe, it's just a minor movement of the probe that you will find the vessel. And the next one is the depth of the insonation. Because it's blind, so you just put the probe on and you just try to change the depth of the insonation. So when you want to find middle cerebral artery, usually you start off with like 50 millimeters, and then you just move the probe a little bit around a little bit to find the artery, and then you know where it is, and you try to follow the artery. So the depth would define your artery as well. Also the direction of flow, because you put the probe, for example, the transtemporal, so you put the probe over at the temporal area. So middle cerebral artery would be moving towards the probe. So anything coming to the probe would be middle cerebral artery most of the time. And if you can trace it into a different depth, that confirms you that it is a middle cerebral artery. And then velocity, usually MCA is higher than ACA and PCAs. So yeah, when you look at the transtemporal window, we usually look for middle cerebral artery first, and then we trace them along. And then we kind of move the probe to the anterior part a little bit to find the ACA. But the anterior cerebral artery is going away from the probe. And then we move the probe a little bit downward to find the ICA, and then a little bit backward. This is just minor movement of the probe. We'll try it on the hands-on session to the back, and we'll find the PCA. So that's for the transtemporal. And then for the occipital, put the probe at the back and try to find the vertebral and move further to the basilar. And the vertebral and basilar are moving away from the probe, right? Because we put the probe here, they are moving away from the probe. So for the transorbital, so we put the probe on the eye. Let the patient close their eyes, and then you just put a little bit of gel on the probe, and then put on the eyes when the eyes are closed, of course. And then you trace the ophthalmic artery down to the siphon. So this is a picture where you do transtemporal approach. Right here, the probe is here, the middle cerebral artery is coming towards the probe here, and you find the MCA, and then put the depth deeper, and then you'll find the ACA going away from the probe. And then you move the probe down a little bit, you find the ICA, and go to the back, you'll find the PCA. So this is, as I said, blind. You can't see the picture. You just have to imagine the anatomy by yourself. So this is what we usually do. Find the arteries like this. So this is an example of middle cerebral artery at the depth of 54, and this is going towards the probe, right? You can see the signal over here, a little bit here, a little small symbol here. This is a probe, and this is the coming to the probe is above the line. So this graph or this picture is coming towards the probe, and it's likely to be middle cerebral artery if you're doing the transtemporal approach. And if you go deeper, you get ACA and MCA together. And then you move the probe, kind of tilt the probe a little bit to the front, you'll find the ACA, which is going away from the probe. You can see that this is above the line, but the signal over here, it shows that it's going away from the probe. It's a little confusing, but you'll do it during the hands-on. And then ICA, a little bit downward. PCA also from the temporal approach, tilting to the back, you'll find the PCA. So transtemporal, you'll find different arteries. I think this is most important part for the anterior circulation. For the transorbital, again, put the probe on the eye, you'll find the ophthalmic artery, and then move deeper to the carotid siphon. And this is what the ophthalmic artery looks like. As you know, the ophthalmic artery is coming from the internal carotid artery, and it supplies the eye, which is not the cranial structure. So the waveform is different. This is high resistant waveform in contrast to the intracranial waveform, which is kind of low resistant. So this is transorbital approach. And then the suboccipital or transforaminal approach is at the back. You'll be looking at the vertebral artery here, and the depth of like 40 something, and moving deeper and deeper. When you reach around 80, it's likely that you'll be reaching basilar artery, and you just follow the artery along. So at the end, you'll get the vertebral and basilar artery from the suboccipital approach. So you can identify those vessels by, looking at the probe, look at the direction of flow, and also the way that you put the probe on. So how can you interpret the result of the TCD findings? So of course we will look at the spectrum, right? We look at the direction of flow, whether it's going in the direction that it's supposed to go, like MCA should coming towards the probe, ACA should be going away from the probe, those kind of things. And next is the velocity. We would measure the peak systolic velocity and the diastolic velocity, and we'll calculate mean flow velocity. The machine would calculate for us. And we will looking at the pulsatility index. And also we'll look at the waveform morphology. Sometimes there's some turbulence flow, sometimes there'll be buoy, you'll be hearing something. So these are the analysis that we usually do from TCD. So this is what the waveform looks like. So systolic, diastolic, very simple. So this is going to be peak systolic velocity. You measure the highest velocity of the flow, and the end diastolic is right here. And the machine would calculate the mean flow velocity, which is actually the time average. You can't just combine these two and do some simple calculation, but you can use some equation to calculate it, but it's usually done by the machine. And then there are some factors that would have some effect on the velocity. Another important measurement is the pulsatility index. The pulsatility index is actually, when you do this equation, it's actually the difference between peak and end diastolic flow velocity. This actually determines the resistance at the further side of the insonation area. So if the resistance is high, the PI is going to be high. If the resistance is low, the PI is going to be low. So in the normal intracranial vessels, we would expect the PI would be around 0.6 to 1.1. If it's higher than this, it's very likely there's some resistance at the end, maybe some vasoconstriction or some stenosis distal to the insonation point. So you can see this is high pulsatility index. This is high resistant waveform. And then this is lower resistant waveform. So for intracranial vessels, we are looking at the low resistant circulation. So it's very likely that it's going to be in this range, and it usually looks like this for the intracranial vessels. So there are some other characters that you have to look at the waveform, the systolic upstroke. Sometimes you have dampened waveform, meaning that you are at the distal part of the stenosis. Or sometimes there's some turbulence. When there's a stenosis, there's turbulent flow, so you can hear the murmur or some turbulence noise over at the area. So coming back to the patient that we're having, we're thinking that maybe she's having a stenosis of the middle cerebral artery. So we perform TCD. So what do we expect to see if she really has a stenosis? So if you do TCD for middle cerebral artery, if the patient is having a stenosis, you will be looking at the MCA like this, right? When you put the probe, it's going to be on this side, on the right side, right? And then you insonate the MCA. So you will be going back and forth, deeper and shallower, and find out what the waveform looks like. If the patient is having stenosis, you would expect the deeper part would be the pre-stenotic site, right? Maybe they have high resistance because the stenosis is over here. At the stenotic site, you will be finding turbulence flow and high velocity because the artery is smaller, so the velocity is going very high. And distally, you'll see the kind of dampened or attenuated waveform because the flow is not going very well, so the velocity is going down. So those kind of things are the things that you would expect in a patient with stenosis. There's some criteria, and Romani has mentioned some of them. And what we expect is to have focal velocity changes, right? If the velocity is the same all in all the depth, it would be normal, or maybe something, no focal stenosis. But if you see focal velocity changes, it's very likely that it's a stenosis, right? And this is what it looks like when we perform TCD on the patient that we are having. So this is at the depth of 65 of the MCA here, depth of 60, depth of 50, and this is 68. What do you think? So the probe is right somewhere over here. So getting deeper, you can see that this is ACA and this is MCA. And the velocity is very high in the MCA right at this point. And going near the probe, the velocity is down and the wave looks kind of dampened or attenuated. So this is actually what the CTA looks like. So at the stenotic site, usually we'll get a very high velocity, and we should measure that and see how high velocity it is, and you can just go to the criteria and look for it. So this patient is having MCA stenosis, and the carotid is fine. And as Romani said, if we find that this patient is having stenosis and it's causing the TIA, we should treat them differently. We should put the patient on dual antiplatelet at least for 3 months, and then high dose statin, and try to prevent the TIA from happening again. If it happens again, despite all those treatment, we may have to think about stenting. So I think that's all for me. Thank you.